and ultimately we'll discuss, something which evades a lot of doctors. They've heard about this, but they don't know what it is. We'll talk about clamp studies, right? So that's what we are going to do in today's lecture. So we have a full plate today in front of us, and let's begin straight away. So Amit, if you can confirm, can you see my screen? Still not full screen. Yeah. Can you see my screen in full screen mode? Yeah, I think, yeah, you're muted probably, Amit. So, okay. I think, yeah, I think it should be visible. Okay, so let's begin. So, like I said, this is going to be four, within this four parts also, this is going to be, one of the four parts. Again, if you have any questions, yes. So if you have any questions, please put it in the chat and we'll discuss it at the logical breaks. So let's first begin with the uh, lesson one, chapter 2, lesson 1, that is insulin resistance in clinical practice, and how you will assess for insulin resistance in your clinical, in your as a clinician. So how will you identify a patient having insulin resistance, and what would be the approach? Okay, so if you see the clinical spectrum of insulin resistance, it could have varying severity, and often it would have multiple organ involvement, right? Now, this is a question which has often uh, been asked, and often, we are trying to understand that, we say that this patient has insulin resistance. How do I know that this patient indeed has insulin resistance, what I speak of? Now, there are, of course, some direct ways of assessment of insulin resistance clinically, but the most important way of assessment of insulin resistance clinically is through the metabolic syndrome concept. Now, if the patient fits into the diagnostic criteria of metabolic syndrome, then we can say indirectly that the patient has insulin resistance. Why this is also important is that that could be a starting point for discussion with the patient on lifestyle measures and also on the treatment options which we can offer to the patient. Okay, so this is the essentially the metabolic syndrome, and metabolic syndrome is the surrogate marker of insulin resistance. So there are direct ways of assessment, right? We'll come to that in a few minutes, but the indirect way, and probably more importantly, the more important way of assessment of insulin resistance is having metabolic syndrome. Now, you'll ask me that why Om is insulin resistance a marker of or metabolic syndrome criteria a marker of insulin resistance. Now, quintessentially, as you remember last time we had discussed, the ectopic and the visceral fats, the fat in the abnormal location or the adipocyte function is the important reason why a person develops insulin resistance. So if you have more fat in the central adiposity and you're already started having consequences of the same, then you are having insulin resistance unless proved otherwise. Okay, so the diagnostic criteria of metabolic syndrome are all well known to us. So you should have abdominal obesity, increased waist circumference, elevated blood pressure, elevated fasting glucose. Again, it can be in the impaired range or in the diabetic range. Elevated triglyceride, and again, triglycerides are very, very important markers of insulin resistance. I will discuss triglyceride more as we go along, and reduce LDL cholesterol. So all these markers, when present, they are suggestive of a patient having insulin resistance. And insulin resistance is very, very common. It's seen in 30 to 40% of adults in developed countries. So it's a very common condition, right? And any three of the five, if present, the patient is said to have insulin resistance. Right. Now, we already discussed how does insulin resistance link with metabolic syndrome. So remember, metabolic syndrome, we are trying to assess for presence of visceral adiposity, right? So if you have visceral adiposity, and visceral adiposity has direct correlation with insulin resistance. Also, presence of metabolic syndrome is a compensatory response of the body, and it's an indirect marker of hyperinsulinemia. Also, you're with the test of metabolic syndrome, you're also already seeing the dysfunction which is associated with insulin resistance, and very importantly, the vascular endothelial dysfunction, which is a very important marker of insulin resistance and the clinical features of that. And it also indirectly gives you altered adipokines, right? And adipokines are basically hormones released by adipocytes, right? So these are all these things makes the clinical assessment of insulin resistance, metabolic syndrome, a good area, a good way of starting point of assessment for insulin resistance. Now, this is where we'll take a little poll, and again, we'll keep taking your questions. So if you have questions, please put it in the chat, and we will take them up as we go along. Right. So now you will tell me which of the following is not considered a component of metabolic syndrome, right? Is it elevated C-reactive protein, waist circumference, triglyceride, HDL, or blood pressure? We already discussed this in a few minutes. Now we'll meanwhile take this as an opportunity to take some of your questions. Okay, so Mehul has asked why fasting glucose of more than 100 is written and not 126. Well, because Mehul, for the diagnostic criteria of insulin of metabolic syndrome, we are taking impaired fasting glucose as the criteria and not full-blown diabetes. So when you have glucose more than 126, then patient is said to have diabetes. Whereas when it's between 100 to 125, it is the patient is said to have impaired. And when you have impaired fasting glucose, that itself you are having criteria for insulin resistance and metabolic syndrome. Remember, we are in a stage right now, we are before diabetes, right? So that's the reason why we do not we take that 100 as the criteria and not 126, right? So it's a good question. Okay, so yeah, so we're taking this poll question. Remember, elevated hsCRP or elevated C-reactive protein, though a very important marker of chronic inflammation, is not a marker of metabolic syndrome or insulin resistance. Now, try and understand this, right? There are two things. One is metabolic syndrome and the insulin resistance criteria, and the other is the chronic inflammation that correlates with the insulin resistance. So hsCRP is a very good marker of the chronic inflammation, whereas the metabolic syndrome is a good marker of insulin resistance. So everybody having insulin, more or less all of them correlate, but at the same time, it's important that hsCRP is not a criteria for metabolic syndrome. Okay, moving on. So, so I think most of you answered this correctly. Okay, so moving on, what happens to the blood sugars as we go along from insulin? So the progressive spectrum. So this Mehul already asked this, and I think this is where we answer this. So initially, what happens is that we discussed this in the last chapter as last lesson as well. So what we are dealing with in a stage, we are dealing with a stage which is before the patient develops diabetes. So what is happening is essentially the patient starts developing insulin resistance, and the body, in compensation to overcome the insulin resistance, starts increasing the insulin production. So you are often in this patient's, you are often in a stage where the patient initially has a lot of insulin resistance, but we are compensating for that. Now, the first detectable abnormality that starts appearing is the postprandial hyperglycemia, right? The post-meal sugars starts, going up. Now, why does this happen, right? A very simple explanation for this. The simple explanation is that, remember, you are looking to increase, you're compensating, but at some point of time, the body cannot compensate for the increased insulin resistance. So at that point of time, the insulin production does not match the insulin resistance and the blood sugar starts going up. So just remember this very important thing. As long as body's insulin production matches the insulin resistance, the blood sugar does not go up. But at the point of time where the body's insulin production cannot match the insulin resistance, that is the point of time you start developing hyperglycemia. Now, when you are in a fasting state, obviously you require less insulin to compensate for the insulin resistance. But when you are post-meal, you actually require more insulin. Now, if the failing pancreas is not able to produce the insulin, it is to some extent will be able to produce the insulin, which is required to suppress the hepatic glucose production, but may not be enough to compensate for the post-meal rise in blood glucose. So the first sign that you start seeing is the postprandial hyperglycemia, and that is the reason why the most sensitive test for detection of diabetes is oral glucose tolerance test and not fasting blood glucose, right? So that's why we do a OGTT to detect diabetes early on, right? So if you want to detect diabetes early, then you have to look at oral glucose tolerance test, both in gestational diabetes as well as in a normal diabetic patient as well. Eventually, what happens? The fasting blood sugar also starts getting impaired, and you have impaired fasting glucose, and then eventually you go on to develop a full-blown diabetes mellitus, right? So that is how the entire spectrum of the event takes place. Now, this is a typical curve of how things happen. We already discussed. So initially, the insulin production matches the insulin resistance. Here, of course, they have said insulin sensitivity, so which is opposite of insulin resistance. So that take it that way. As long as both the things are matched, you don't develop hyperglycemia. But once the insulin production cannot match the insulin resistance, at that point of time, you start developing diabetes. So it's very clearly seen in this curve, which we have shown here, right? So yeah. Okay. So this we talked about. There is a compensatory phase, and then there's a tipping point at which the insulin production cannot match the insulin resistance, and at that point of time, you develop hyperglycemia. Now, if you understand this concept, trust me, you have understood type 2 diabetes. So I'm repeating this concept again. Initially, there is insulin resistance. The body compensates for the insulin resistance by producing more insulin, right? As long as the insulin resistance and insulin production matches, the body does fine, right? But at the point of time where the insulin resistance is, the insulin production does not match the insulin resistance, at that point of time, the blood sugar starts going up, right? And that's the tipping point, and that's where you start developing high blood sugar, hyperglycemia, or in common words, type 2 diabetes. Now, some direct ways of assessment of insulin resistance are these tests, which are these clinical features. That is acanthosis nigricans, and you have skin tags, right? So you can see the pictures over here. So acanthosis nigricans is a very good clinical assessment of hyperinsulinemia. So you have velvety, hyperpigmented, hyperkeratic lesion, typically see in the axilla, right? In the neck, in the axilla, and the groin. So if you don't see the neck, you can actually expose the patient and see in the axilla also. It's often present in the axilla as well. And its severity also correlates with severity of insulin resistance. So more acanthosis you have, more insulin resistance you have. Now remember, acanthosis is actually not because of insulin itself, but it's because of the insulin. We discussed specifically spillover last time. So when you have very high levels of insulin, ideally it is supposed to act only on insulin receptor. But when the levels are very high, it spills over and starts acting on the IGF-1 receptor, and it starts acting on the IGF-1 receptor. It stimulates that and starts producing this type of lesion, which is called acanthosis nigricans. Similarly, you have a similar mechanism with skin tags, and you can see some of the skin tags. So if your patient has skin tags or insulin or acanthosis, think that the patient is already having insulin resistance, and it will be a good time for you to start talking to the patient about potential management. Okay. Moving on. So again, at some point of time, you start having some clinical manifestation of insulin resistance. So in women, one of the most classical clinical manifestation of insulin resistance is polycystic ovarian syndrome, PCOS, right? So PCOS is the clinical manifestation of insulin resistance at the ovarian level. So clinical features you all know, you have irregular cycle, hyperandrogenism, and polycystic ovaries. And then again, it is two things. One is you have insulin stimulates ovarian androgen production, right? And there is Zika cell hyperplasia, right? So that's the mechanism of PCOS. In men also, they start developing obesity, and because of insulin resistance, they start developing hypogonadotrophic hypogonadism, right? So male hypogonadism is also a result of insulin resistance, right? So again, some of these men start having experienced sexual dysfunction and start developing some features of hypogonadism, and this also is because of insulin resistance, right? Now, the reproductive abnormalities actually appear early, right? They appear early before they develop diabetes. So it's again something very important again. So a girl with PCOS is more likely to develop diabetes in future, and she's already having insulin resistance at this point of time, right? So that is something which is a very important telltale sign of a patient having this, right? Now, let's see the insulin resistance and PCOS spectrum in more detail. Now, basically, one of the things is that this high insulin level starts stimulating the theca cells of the ovary, which increases androgen production. Now, another thing which happens is that there is one sex hormone binding globulin. Now, the sex hormone binding globulin, or SHBG, what happens is that, remember, it binds with the androgen, it binds with the testosterone, right? Now, insulin resistance, right, reduces, or a very high levels of insulin reduces the sex hormone binding globulin, and hence increases the free testosterone level in this women, and that also has increased clinical effects in terms of hyperandrogenism, and this becomes a vicious cycle again. In women, when you have increased androgen, they tend to have more of visceral adiposity again, and this becomes a vicious cycle. So you're more androgens, more visceral adiposity, more insulin resistance, and again this becomes a vicious cycle, right? And again, insulin also has direct effect on the LH stimulated androgen production. So overall, insulin itself increases androgen production in women, and also it leads to more free androgen levels in women. But in men, it's exactly the opposite. It's very interesting. So in men, it does something opposite, right? So it leads to suppression of the axis in men, and then hence leads to. So it's a very interesting dynamic that you see in men versus women. So the important area, remember you to understand, is that when you have insulin resistance, one of the early features in women is PCOS. In men, you start developing hypogonadism, and this is one of the early ways in which you can pick up this clinical features, right? Again, in terms of liver, you start developing fatty liver, and again, presence of fatty liver is also a sign of insulin resistance. So if you notice fatty liver, that means you patient has insulin resistance unless proved otherwise. And this is a very important thing you have to understand. So remember, fatty liver precedes the patient developing diabetes, and that's something you have to understand. Again, some of these patients already start having cardiovascular manifestations, as you already saw from the metabolic syndrome criteria. So they start having dyslipidemia, high triglyceride and low HDL and small dense LDL are the classical triad of insulin resistance spectrum of a dyslipidemic profile. You start developing hypertension, and remember insulin in itself, remember these patients have high insulin levels, but the insulin does not act, right? So remember I told you the rhyme of ancient mariner last time, right? So water, water everywhere, but not a drop to drink. That is exactly what it is. But this increased insulin does continue to have some other effects, and one of the effects it has is it acts on the renal tubules to enhance sodium reabsorption. So it enhances sodium reabsorption, increases sympathetic activity, and ultimately leads to more of hypertension, right? Very importantly, at the endothelial level, it produces endothelial dysfunction and leads to impaired nitrous oxide production. That is also one of the reasons why these men have erectile dysfunction also, right? So that's something which is again a correlation there. And ultimately, it leads to a prothrombotic state, a pro-inflammatory state, and that ultimately can lead to sometimes plaque rupture or dysfunction or unstable plaques, which can lead to a coronary event also, right? Very importantly, there's many few years back, there was a study which they did with pioglitazone. We'll be discussing that next time. But they used pioglitazone in patients without diabetes having TI, right? Transient ischemic attack. And this TI patients who are given pioglitazone, that reduce the risk of them developing stroke, which is very interesting, right? So what you have to understand is that insulin resistance in itself is a risk factor for cardiovascular disease of myocardial infarction and stroke. And that is the reason why, if you remember last time I told you that by the time the patient develops diabetes, it's actually too late. You should start intervening in these patients before they develop diabetes at the stage of insulin resistance, because the cardiovascular problems actually start before the patient develops diabetes. And that's a very important issue that you need to deal with, right? Again, if you have any questions, please don't raise your hand. It's a little distracting if you raise your hand. It pops up on the screen. What I suggest is if you have a question, please put it in the chat box. So we'll answer them at as the lecture goes along. Okay. Right. So we already said the cardiovascular disease, and the cardiovascular risk factors actually precedes the patient developing type 2 diabetes. And hence it is very important that the insulin resistance in itself is seen as a disease and it's tackled independently of the same, right? Again, you can have other clinical manifestations. So you could have sleep disorder, you could have some cognitive decline, right? In fact, Alzheimer's disease is actually known as was once called a type 3 diabetes. Of course, that term is now reserved for something else. But Alzheimer's disease in itself is thought to be insulin resistance at the CNS level, right? There is increased risk of cancer, especially endometrial, breast, and colorectal cancer. And we discussed last time that when you have insulin, insulin is a growth promoter. And if you block one pathway, the MAP kinase pathway continues to be active. And though insulin, metabolic effects of insulin at the cellular level is dampened down, the other aspect, that is the growth aspect, continues, and hence these patients with insulin resistance are at an increased risk of developing cancer. Also, you have certain patients that have pseudoacromegaly like features. So there is increased, sometimes they start developing enhanced, the soft tissue starts growing. There is thickening of soft tissue, right? In fact, clinically, if you see, some of these patients actually look a little bit acromegaloid, right? Even without growth hormone excess, right? So they start developing, and remember, this is because of high insulin acting on the IGF-1 receptor, and these patients start having some clinical features very similar to acromegaly, right? So some of these subtle clinical signs may be visible in some of the patients, and if you again are a good clinician, you will be able to pick this up as cues for your patient having insulin resistance. Okay, so like I said, this is a summary of clinical cues to insulin resistance. So one is, of course, your metabolic syndrome criteria: increased waist circumference, acanthosis nigricans, and skin tags, presence of cardiovascular things, hypertension, dyslipidemia. In women, you could have PCOS. In men, you could have hypogonadism, and of course, other metabolic manifestations and fatty liver. All of these things point towards the patient having clinical insulin resistance. Okay. So again, remember, we have to, like I said, pick this up before the patient develops diabetes. Early identification is very important because you will be able to prevent certain complications if you take care, right? So this is the end of lesson 1, chapter 2, lesson 1. And here the idea was to tell you that how you can clinically assess for insulin resistance even before you send the patient for tests. And again, a good thing is to do a waist circumference measurement. You do a look for acanthosis, skin tags, and certain clinical signs like presence of some pseudoacromegalyte features and so on. Right? Okay. So we'll take a couple of questions which are there. How much should be insulin BSL ratio? We'll come to the biochemical aspects in a few minutes. And Mohammed Shaigan has asked, insulin resistance, one of the reasons for isolated diastolic hypertension? Yes, insulin resistance does produce hypertension, and in fact it can produce diastolic hypertension also, right? Isolated diastolic hypertension, yes, it can, right? So that it's in itself a marker of endothelial dysfunction, right? So yes, I think that answers these two questions we have. Now please put your questions in the chat, and we'll keep taking that questions as we go along. And we'll, of course, have in the end, if we have time, we'll be discussing more of the questions as well. Now, let's move to the chapter 2, lesson 2, where we'll be discussing about some clinical insulin resistance syndromes. Now, these are very interesting syndromes. And why you have to understand this syndrome, you'll probably not see this syndrome in your clinical practice. Or if you do, you will be able to diagnose it, right? It's very these are all very, very rare syndromes, but these are important to know because this helps you understand what actually insulin resistance curtails, right? It entails. So that is something which is the reason why you should understand these insulin resistance syndromes. These are very interesting syndromes. And again, hold your breath because it's going to be really interesting things, right? Now, broadly, you categorize insulin resistant syndromes into 3 categories, right? One is defects in the insulin receptor gene. Second is having antibodies against insulin receptor. And third is lipodystrophic syndrome. So these are the 3 conditions, 3 categories in which you categorize patients with insulin resistance syndromes. Okay, now, first let's take problems with insulin receptor gene. Now, last time, if you remember, we had told you that the classical insulin resistance that we see, the problem is not at the insulin receptor, but the problem is the downstream effect of the insulin receptor, right? So insulin receptors are there, but the insulin receptors action downstream is affected, right? So that is what happens in a clinical insulin resistance, that classical features, that classical thing that we see in clinical practice. But when you have defects in the insulin receptor gene itself, either the gene is not properly functioning or the insulin receptors are not properly formed, then they tend to have insulin receptor, these defects, which are generally, the problem here is generally because of the insulin receptor itself, lack of insulin receptor itself. Now, the most severe form, remember, these are conditions which are graded in severity. So there are 3 grades of it. The most severe form is known as leprechaunism or Donoghue syndrome, where you have almost complete absence of insulin receptors. You have moderate severity condition called Rapson-Mendenhall syndrome. And then you have the mildest form called the type A insulin resistance syndrome, right? So these are the 3 conditions. We'll see this. So these are the spectrum of the insulin receptor defect, right? And the defect is basically in the INSR gene. So you have mutation in this gene. And again, the severity of this correlates with the survival of the patient, right? Again, generally they're autosomal dominant, autosomal recessive conditions. And generally they tend to have either the patient would have either a homozygous or a compound heterozygous mutation. And that's how they clinically would have these syndromes, right? Now, leprechaunism is the most severe form, right? Where you have the most, defect in insulin resistance, insulin receptors. So you have almost complete absence of insulin receptors. And because of that, it's an extremely rare condition. You can see a patient, which is shown here. And in this, you have so remember, insulin is an anabolic hormone and it is necessary for growth, right? Now, if the insulin receptor is absent, you still have insulin, but the growth does not take place. Remember, I told you this categorically, that in the clinical patient with a lifestyle disorder, when you have insulin resistance, the defect is actually it's a downstream effect, and the insulin receptors are there, and the insulin binds with the insulin receptor, but the downstream effect at the metabolic level is defective, but the growth level is still intact. But these patients have defect in the insulin receptor itself. So because of that, what happens is that the growth also does not take place, right? So they have very poor growth. So they have intrauterine and postnatal growth retardation. They have a classical elfin-like phase, as you can see here. They have severe insulin resistance, and now they have paradoxical hypoglycemia, right? So they have, remember, insulin is necessary for the glucose to enter the cell, and this glucose does not enter the cell. And of course, the cells, like I said again, once again, you have water everywhere, but not a drop to drink. They have very high insulin levels if you can measure that, and they have typical features, clinical features like this, right? So you can see this child with severe, acanthosis, darkening of skin, hypertrichosis, right? And generally, this is a very poor prognosis. There is no treatment for this, and the patient generally dies within first year of life, right? So this is a most severe form, which is known as Donohue or leprechaunism, right? Then you have a slightly milder form, which is called Rapson-Mendenhall syndrome. You can see the child over here, right? And this child actually survives till up till some period of time. Generally, they can survive up till puberty, up to adolescence. And in adolescence, naturally the insulin resistance increases, and then that becomes their demise, right? So this is an intermediate form of insulin resistant defect. Again, they tend to have a growth retardation. Again, as we discussed, insulin has impact on growth. So they have some insulin receptors, but they're not completely absent. They generally tend to have metabolic clinical features. They start developing diabetes very early on, by 5 to 6 years of age. And when you try to treat this condition, it's very difficult to treat because the insulin requirements are very high, right? Very, very high insulin requirement. They tend to have this type of acanthosis. You can see very severe acanthosis nigricans and hypertrichosis, right? So you can see the more extreme form of insulin, acanthosis, and this. That also tend to have other growth abnormalities like dental abnormalities. You can see this pineal gland hyperplasia, and they can survive up till adolescence, but they generally die by that point of time. Very difficult to treat, and again, no specific treatment that you can give, and they start developing diabetes also at some point of time, right? So that's how typically these patients present, right? And the mildest form of this condition has what is known as, what was once described as hair end type of picture. So they tend to have hyperandrogenism, insulin resistance, and acanthosis nigricans. Uh, Generally, again, this is seen, this is the mildest form. It's generally seen at adolescence or puberty. So it's very difficult to distinguish this from a usual insulin resistance. And in fact, not much you can do to diagnose, but they're generally more extreme end of spectrum. So if it's a girl, typically the girl will present like PCOS-like features, but they'll have more extreme forms of that, extreme clinical features of that, right? So that's how typically they are, right? And patients, the only thing is, you can distinguish this from PCOS is that these girls will generally be lean, whereas PCOS girls tend to be obese, right? Generally, so they tend to have a more leaner form of clinical present. They are more lean because again of the growth, right? The growth defect is there, right? They tend to be, again, there has to be some form of growth defect also. So that is how they clinically. So they are generally shorter, leaner, right, compared to a obese person, or those who have metabolic associated insulin resistance, who tend to be slightly taller and tend to be again more obese, right? So that is the clinically how you will again a clinical cue of possible presence of type A insulin resistance syndrome. Okay, so you can see this features of type A insulin resistance. You can see clinical features of insulin resistance, and again severe acanthosis nigricans with a modified Ferryman-Gallagher score of much higher, of 32, right? So they tend to have more severe, especially these are recognized in girls because they will present with features of PCOS or hyperandrogenism. Okay, so let's take an audience poll at this point of time. And this is a very interesting question, and you should be, I'll tell you the thing here. Okay. So let's run this poll. Okay. So which of the following is not a characteristic feature of genetic insulin receptor defect? Okay. So which of these? So I'll answer this question. I'll take a couple of questions which are there from the audience. So Kashif has asked, is every non-alcoholic fatty liver a sign of insulin resistance? More or less. So when you have a non-alcoholic fatty liver disease in itself, it's definitely a sign of insulin resistance, especially at the liver level, right? In itself, the accumulation of fat in itself at the liver is a sign of insulin resistance. So yes, answer is yes. Murali has asked, could elevated SHPG could mark insulin resistance? No. So there is reduction of sex hormone binding globulin because of insulin resistance. But in when you have more of estrogen, it increases SHPG. But when you have insulin resistance, it actually reduces SFPG. So that's something which you can keep in mind. Okay, Dr. Sumit has asked, what are the signs of decreasing insulin resistance when we begin lifestyle? Oh, we'll come to that. We'll come to that when we discuss the treatment aspects. There's going to be that being discussed. Okay, right. So the answer to this question here is that in this poll question is that the interesting thing we have to remember is that how will you differentiate a lifestyle or a metabolic associated insulin resistance from a genetic insulin defect? Couple of things. So all these things will help you do it. Acanthosis nigricans will be present in both, but will obviously more severe in somebody who is having genetic insulin defect, insulin receptor defect. Hypertriglyceridemia, which is a characteristic feature of insulin resistance in metabolic conditions, is not seen in patients with genetic insulin defects, right? So that's a very important thing. So they don't have hypertriglyceridemia, and that is something which is very important to note. Again, they both will have extreme hyperinsulinemia depending on the severity, but naturally the condition, the genetic defects tend to be more. Growth abnormalities again, tend to be more with any genetic form of insulin resistance, but again, insulin receptor defect tend to be more. So again, this would be sort of again not a wrong answer. Okay, is it not a correct? Yeah, so they are a feature of insulin resistance receptor defect, right? And hyperhidrogenism field is also a clinical feature of that. So hypertriglyceridemia is not seen with genetic insulin receptor defects. That's something which you have to understand. And again, that's one way in which you can distinguish. Other ways include again these patients tend to be lean, whereas those with metabolic conditions tend to be obese. These patients tend to be shorter. Growth retardation will be seen, whereas a typical metabolic situations they will be tend to be more obese. Okay, right. So I can end the poll, and I think good that a lot of you got this answer correct. I think 54% got it correct. So majority did get this answer correct. Okay, right. So again, this is the answer thing, right? So hypertriglyceridemia is not a characteristic feature of genetic insulin receptor defects, right? So these patients do not have, whereas the other conditions which you're going to see now will have hypertriglyceridemia, and these are that's how you'll distinguish between these conditions. Now, one very interesting condition, which is an acquired condition, but an important insulin resistance syndrome, is type B insulin resistance syndrome, right? So type A is when you have defect in the insulin receptor, so your lack of insulin receptor. But type B is a condition where you have, it's an autoimmune disease. So you have antibodies against insulin receptor. So you don't have defects in insulin receptor, you have antibodies against insulin receptor. Now, the interesting thing is, right, this is a disease which is generally seen in middle-aged females. Patients tend to have severe insulin resistance. Now, but the interesting thing here is that these antibodies tend to be either stimulatory or tend to be blocking antibody. Now, if there are blocking antibodies, both actually coexist in the same patient, right? Now, if you have more of stimulating antibody, what will happen? It will stimulate the insulin receptor and the patient will present with hypoglycemia. Whereas if you have blocking antibody, what will that do? It will block the insulin receptor and it will prevent the insulin from binding with the insulin receptor, and hence it will produce hyperglycemia, right? So when you have more of blocking antibody, you tend to have high blood sugars. And when you have more of stimulating antibody, you start developing unexplained hypoglycemia. So that is a very interesting feature of this condition. And in the same patient, there can be a shifting of this condition, right? So at some point of time, the patient can have blocking antibodies and more of blocking antibodies, and hence can present with severe hyperglycemia, which is very difficult to treat. And sometimes they can present with hypoglycemia, which again becomes very difficult to treat, right? Because they have stimulating antibody. So it's a very interesting dichotomy of condition, right? Also, this is also seen in Graves' disease. So a lot of patients, again, a lot of doctors need to understand that Graves' disease also, you have TSH receptor antibody. It's very, in fact, this is the condition which is most similar to this is actually Graves' disease. So in Graves' disease, you have either stimulating antibody or blocking antibody. And when you have stimulating TSH receptor antibody, you tend to have hyperthyroidism. Whereas when you're blocking TSH receptor antibody, you tend to have hypothyroidism. So that's something which you have to keep in mind, right? So that's a very interesting area. And generally in Graves' disease, you tend to have, of course, hyperthyroidism, more of stimulating antibody. But in certain patients with Graves also, you can have fluctuating course. But here, fluctuating course is very, very common. And hence, patient can present with hypoglycemia or hyperglycemia. So that's a very interesting situation which you need to understand this, right? Again, I'll give you a typical case example. We have seen patients with type B insulin resistance. In fact, I have about 3 or 4 patients of this type in our follow-up. This is a 42-year-old patient with SLE who had presented with severe hyperglycemia, had weight loss despite hyperglycemia, had acanthosis nigricans, had normal triglyceride despite having severe insulin resistance. This patient actually required more than 3 units of insulin a day. So actually patient presented with hyperglycemia, right? And this, we ultimately diagnosed this patient as having severe insulin resistance syndrome, right? So type B insulin resistance, you have, like I said, both blocking and stimulating antibody. It vexes and wanes over a period of time. And generally, apart from the routine thing, you have to give immunosuppressant to these patients and require very careful monitoring, right? So that's something you have to be very careful about. And the final group of disease which leads to insulin resistance are the lipodystrophic syndromes, right? So these are lipodystrophic conditions. Now, what are lipodystrophic syndrome, or what is lipodystrophy? This is a very important thing you have to understand this condition, right? Now, lipodystrophy means, now if you remember, I told you last time, if you understand lipodystrophy, you actually understand how pioglitazone works, right? Very interesting, right? So that's something you have to understand this. Now, what you have to understand is, last time I told you that the adipocytes are living, breathing cells. They are not just dead tissue. They are not just dead storage tissues. They are living cells. And in fact, the root cause of all the metabolic problems are problems with adipocytes. Now, if you have good amount of adipocytes, right, the adipocytes take on all this fat. It takes on this fat, right, and it stores the fat. And this fat, which is warmly, cozily stored, does not create any problem. But when you start having that limited number of adipocytes, when you start stuffing it with more fat, that is the point of time you start developing dysfunctional adipocytes, which lead to the clinical features of the problem, right? Now, one way of countering this problem is reducing the fat, which is a good way. But the second way is, if you can increase the number of adipocytes, then the fat gets distributed amongst the adipocyte, and this dysfunctional adipocyte problem does not exist anymore. So that's a very interesting way of looking at this entire thing, right? So pioglitazone, what it does is increases the number of adipocytes, and by increasing the number of adipocytes, you are able to distribute the fat amongst adipocytes, and hence you are able to solve this clinical conundrum, right? Now, lipodystrophy, exactly the opposite happens. In lipodystrophic syndrome, what happens is that you have less number of adipocytes. And because you have less number of adipocytes, what happens? The adipocytes cannot store the fat. And because they cannot store the fat, right, whatever limited adipocytes, they are only able to store the fat. And there is not, so rest of the fat starts getting spilled as free fatty acid. And this spilled free fatty acid is, remember, the root cause of the major dysfunction, right? So lipodystrophic syndrome patients generally tend to have less number of congenitally, or in certain cases acquired, they have less number of adipocytes, and because of less number of adipocytes, they tend to have insulin resistance, right? So there is loss of adipocytes. Now there are four, if you say a 4x4, there are four categories. One is based on, so if you categorize lipodystrophic syndromes, one is either you have generalized or partial. So generalized lipodystrophy is when you have entire body, there is no fat. There are no fat cells, there are no adipocytes. And second is partial, where you have in certain parts of the body, you tend to have fat cells and other parts you don't have. And it can be either congenital lipodystrophic syndromes or acquired. Acquired generally are autoimmune in nature, right? And the metabolic consequences, of course, you have absence of the functional adipocytes, and then insulin resistance. And then so remember, adipocytes are a sink. It takes up the fat, and it's actually, in a sense, prevents the patient from developing insulin resistance. But if you don't have that, you tend to have this type of picture. In fact, there is a theory for a long time that Indians ourselves, the South Asians ourselves, we are the thin fat Indians, right? We are genetically having some form of, all of us are having actually some form of lipodystrophic syndrome. That is the reason why we tend to have less of subcutaneous fat and more of fat, more of the adipocytes in the visceral and the region, and hence tend to have more of insulin resistance. Whereas the Westerners tend to have more of subcutaneous fat, so the fat adipocytes there are able to take up the fat and hence have less of these problems, right? Metabolic issues, right? So I hope that makes sense. But of course, they also, if they keep stuffing the fat and overwhelming the adipocytes, they also, of course, go on to develop insulin resistance. But we tend to develop it early because of this kind of thing, right? Now, let me give you some examples. So one is this condition called Banandari-Seep syndrome, which is a congenital generalized lipodystrophic syndrome. Here, these patients tend to have almost no fat cells, right? They are complete absence of fat cells. So they don't have adipocytes. And you can see one classical picture on the left, and you can see some adult variants of that on the right. These people actually survive, so they don't die, but they start having clinical features of insulin resistance. Now, what you can see here is this girl, what she's having is she's having acromegaloid-like feature. Now, first of all, you can see that she has literally no fat, right? So what you see is actually more of probably has a little bit of ascites, so might have we already having liver dysfunction, but they generally don't have any subcutaneous fat, right? It's actually more classically seen on the right side where you can see the patient has very low body fat, right? But so where does this fat go? Fat starts getting deposited in the ectopic location. So they start having liver fat. So they start developing liver disease, right? They develop, the cirrhosis of liver and the MSLD type of spectrum much earlier, right? So the fat starts getting deposited in the organs of the body rather than from in the in these adipocytes where it is supposed to be deposited, right? Because of the high insulin levels, and this high insulin levels starts having specificity spillover, starts acting on the IGF-1 receptor, which I told you several times earlier. So patient starts having acromegaloid-like features. So both these patients, the adults, the male and female, you can see they appear acromegaloid. But because of the fact that they don't have any subcutaneous fat, you can see the actual muscles are very prominent. So they actually look, well, quite athletic, but they are actually suffering from very severe disease condition. They tend to have severe acanthosis, as you can see the girl on the left side, and they tend to have hepatomegaly, cirrhosis, ultimately developing cirrhosis. And because of these are patients who have very high triglyceride level, remember, and because of that, these patients tend to have pancreatitis and can develop pancreatitis and ultimately develop diabetes, pancreatitis, and all these clinical complications. So this is a case study of, if you understand this, you understand why it is very important to have fat cells in your body, right? And this condition is a classical example of why not having fat cell is a problem, right? Okay. Then you have, of course, partial lipodystrophic syndrome. So you can see this is an example of partial lipodystrophy, where you have fat in certain parts of the body, but certain parts of the body you don't have fat. So a typical example is when you have central fat cells, but on the peripheries you don't have fat, right? These are partial lipodystrophic syndrome. Now, this partial lipodystrophic syndrome can both be familial or can be acquired, right? So acquired conditions are generally tend to be more of autoimmune in nature, right? So acquired are generally autoimmune conditions, okay? Right. So this is these are some examples. This is a condition called Dunningham syndrome, where you tend to have loss of fat from from the trunk, buttocks, and upper part of the body, and fat accumulates in the face, supraclavicular fossa. So they appear actually Cushingoid, right? And they of course have acanthosis, and in women they have other features of insulin resistance. So this is a typical in Cushing's, it's a very typical something like Cushing's, right? So you said central fat, but the limbs are actually thin, right? So this stick-like figure, right? So that's a potato stick, they say, right? That kind of figure, right? Okay, so the partial lipodystrophic syndromes, again, generalized lipodystrophy can also be acquired. So acquired general lipodystrophy syndrome, the congenital form is called Banandari-Seep syndrome, but the acquired form is called Lawrence syndrome. Acquired partial lipodystrophic syndromes, there are again various variants. Other one you saw is Dunningham. The other one is Barraquer-Simons syndrome. And then similar thing is also seen with HIV patients with the use of antiretroviral drugs, right? Especially ritonavir and those class of drugs. They tend to have peripheral fat loss with central fat accumulation, and they tend to have insulin resistance and dyslipidemia, right? So one of the acquired way is HIV lipodystrophy, which is also, if you can see in a sense, very similar to these kind of syndromes, right? Okay, so when should you suspect insulin resistance syndromes? Again, patient has severe insulin resistance, severe acanthosis, and so on. Very high insulin levels, fasting insulin levels more than 100, very high levels. If they're diabetic, they require very high doses of insulin. Again, they tend to be generally lean individuals with signs of insulin resistance. So obese individual with insulin resistance, you can understand. But a lean patient with insulin resistance, especially severe ones, And then unusual fat distribution, like you see in lipodystrophic syndromes, tend to have hormonal features like hyperandrogenism in females, early onset diabetes with atypical features and severe, insulin resistance, and they, diabetes without metabolic syndrome features, right? So this is how typically these patients actually can be thought of. And again, if you keep your eyes and ears open, you might actually be able to pick up some of these patients, right? So it requires good clinical understanding of these diseases, and of course, you can do certain tests, specialized tests also, to actually look at, right? And of course, management are syndrome specific, so all of these conditions will have different management, right? Generally, there's nothing much you can offer in certain conditions. Basically, you just have to wait and watch, maybe hope for having certain diseases. Very interestingly, this is an argument which a lot of experts also make, is that we have been looking at medicines which tackle diabetes, but how many medicines do we have which actually tackle insulin resistance, that is, which is the root cause of type 2 diabetes? Not many. Of course, you have the PPR gamma, that is the lobiglutathione and pioglitazone. But there are of course other like SGLT2 and GLP which reduce the fat. So there are indirect ways. Metformin, of course, known to reduce insulin resistance. So there are indirect uh, medicines which are there, but primarily, we don't have very powerful drugs which actually reduce insulin resistance, and that's why you tend to have, again, a little bit an area in future where therapeutic, areas could be looked at, right? There could be certain, again, emerging therapies here. So there are novel insulin sensitizers which are being developed, monoclonal antibodies against insulin receptor, recombinant leptin analogs, for lipodystrophies are, metrolleptin and some things are being developed. Gene therapies, adipocytes tissue transplant has been thought to be a potential treatment option and so on, right? So there are emerging therapies, but these are generally tend to be more of, still experimental, right? So what you have to, the purpose of the lecture 2 was to make you understand that there are conditions like this, and you have to be aware of these conditions and probably make a diagnosis if you could in your future. I think that would be a great thing. If you do ever make a diagnosis of one of these conditions after listening to this lecture, do tell me about it, right? So I think, it would be a great honor for me to having helped you make a rare diagnosis. Okay, so thank you for lecture 2, and these are some references on this which you can read, more of. Let's take a question which is there. NFLD can be confirmed by USC. I think, Mehul, NFLD, we had a separate 4-part series, just like we are having right now, a detailed series on MFLD. It's there, still there, probably there on technology.com. We'll have more of that in future. So we'll discuss MFLD, quite separately. We had discussed in great detail in another lecture series. We'll not be discussing that in detail here. We'll be focusing right now on insulin resistance conditions. Okay. Right. Yeah. So let's look at the lecture number 3. And now let's come to the quantification of insulin resistance through biochemical means, right? So what we discussed so far was how clinically you will assess for insulin resistance. And now let's discuss the biochemistry or the lab test, which can help you determine insulin resistance. Okay. So the biochemical aspect, this is where we'll be discussing the HOMAs and quickies and so on. Okay. Now, before I begin, let me tell you this very important thing, right? 2 important principles you have to understand. First and foremost, if the patient has clinical features of metabolic syndrome, patient has acanthosis nigricans, patient has PCOS, girl has PCOS, you don't require tests to confirm insulin resistance. Patient has insulin resistance unless proved otherwise. Now, again, if you have, people of other specialties listening to this, especially gynecs and dermatologists, please understand this. I often see them ordering fasting insulin levels or HOMA-IRs in girls with PCOS. Don't do that. You don't need this test to prove. You don't need to prove it. A girl with PCOS has insulin resistance unless proved otherwise. Unless you're looking for one of these rare syndromes, which are very rare, again, 1 in 10,000, 1 lakh. Unless you're looking for those conditions, it's not useful to do these tests. Do not ask for HOMA-IRs and we'll discuss HOMA-IR, but don't ask for, they are useful for research. They're not useful in clinical practice. That is first. Second thing is, I say this in many of my lectures, you have to understand this fundamental concept. If you're asking for a test, is it something which is a marker of a disease, or is it a target? Right? So is it an indicator or is it a target? Okay. This is a very important thing. For example, a classic example I give you is triglyceride. Now, mildly elevated triglyceride is a very important marker of insulin resistance. So if you have triglyceride of 300, 400, 200, it's a very important marker of the patient having insulin resistance. But should you try to reduce the triglyceride? Only if your triglyceride levels are 500 or 1000, then you should consider reducing triglyceride to prevent pancreatitis. But when you have triglycerides of 200 and 500, up to 500, you don't actually require to reduce triglyceride. Consider it as a marker and not as a target, right? But if it's more than 500 or 1000, definitely consider as a target, right? So even triglyceride in the same test in itself has this dichotomy inbuilt. And very important here is that don't try to measure insulin levels or HOMA-IRs, and don't try to target HOMA-IRs as a form of treatment that HOMA-IR is reducing. No, that is not how you do. HOMA-IR is just an indicator. It's not a target. Okay. So this essential thing, if you understand this fundamental principle, it's a very important fundamental principle of endocrinology. And this is something you need to understand in essentially when you're discussing, when you're treating your patients in clinical practice, right? Now, how do you measure insulin resistance biochemically? And remember, most of this is mainly for research rather than for clinical practice. For clinical practice, clinical signs of insulin resistance are far more important than these lab tests, right? So please understand this, right? Now, the first is direct measurement of insulin resistance, gold standard. And the gold standard are hyperinsulinemic euglycemic clamp, which we'll discuss in the next lecture, and the insulin suppression test. These are two gold standards for insulin resistance direct measurement. Then you have indirect measurements. So indirect measurements, you have oral glucose tolerance tests with insulin resistance calculation and certain tracer studies. And then the ones which we use in clinical practice, right? Though I'm saying that don't use it indiscriminately, are surrogate markers of insulin resistance, which are HOMA-IR quickie, triglyceride glucose index, and EGDR. We'll discuss these things in a minute. Okay. Now, let's first the gold standard, which is euglycemic clamp. We'll discuss euglycemic clamp in the next lecture. So I'll just hold this for now. Okay. Then you have insulin suppression test. Now, last time, if you attended the lecture last time and we had some questions in the end, one important fundamental principle I told you about endocrinology is that if you want to confirm the diagnosis of an endocrine disorder, remember an endocrine disorder is either the hormone is in excess or hormone is deficient. Now, if his hormone is in excess, you should try to suppress the hormone and see if it is able to, you are able to suppress it. For example, Cushing syndrome. Cushing syndrome is an excess of cortisol. So what test do you do for Cushing syndrome? You try to suppress the cortisol, that is dexamethasone suppression test. Whereas adrenal insufficiency is a condition where you have deficiency of the cortisol and you try to stimulate the cortisol. So you do a ACTH stimulation test. So that is a fundamental difference, right? Same way, if you're suspecting that the patient has insulin deficiency, like in type 1, then you do a mixed meal stimulation test. But if you're thinking that the patient has insulin resistance or insulin is in excess, then you should try to suppress the insulin. And this is where you have insulin suppression test, right? So of course, you have heard more of mixed meal stimulation test because it is more used in clinical practice. Insulin suppression test is again more of theoretical and lab related test. We don't use it in clinical practice, but again, this is something which can be done, right? So how do you suppress insulin production? You suppress insulin by using a hormone called octreotide or somatostatin, right? So essentially what you're doing in insulin suppression test is giving octreotide or somatostatin to suppress the insulin, but it also suppresses glucagon So to suppress the insulin and glucagon production, and that's essentially the basis of insulin suppression test. That is all you need to know about insulin suppression test. You don't need to know. It's an experimental thing. You are not going to use this in clinical practice. There is no use of this in clinical day-to-day practice. Now, another test, which again more theoretical and more useful in research, is called oral glucose tolerance test with derived indices. So in this test, what you do is just like you do a OGTT, you take a fasting sample, then give 75 gram of oral glucose and take samples at 0, 30, 60, 90 and 120 minutes. And then along with the glucose, you also measure the insulin. So in a standard oral glucose tolerance test, we just measure the glucose. Here, what you're doing is you're measuring the glucose as well as you're measuring the insulin levels, right? And from that, there are three indices which you can, there are many indices, but three ones which you commonly use. One is called the Matsuda index. Second is called the Stump Wall index. And then third is called the OGIS, right? Again, these are complex calculations, more useful for research than clinical practice, but Matsuda index has stood the test of time for research. So currently the best test to do for research for insulin resistance is the Matsuda index. You can see the formula over here, right? So you have fasting glucose, fasting insulin, and mean glucose of these values, and the mean insulin levels of the OG or of the oral glucose test, right? So this is how you calculate the oral glucose tolerance test. It's actually much easier to do because it's an oral test, can be done in outpatient. Again, if you're doing some sort of research studies on insulin resistance or using drug which suppresses insulin resistance, then this could be a test which could be useful for you to consider, right? Then there are tracer methods where you can use radio tracer, right, to see the insulin, action and insulin resistance. But again, this is again mainly used for research purpose. But the test which we have heard a lot about uh, has but should not be used that frequently is the HOMA IR. Now, I often see something even worse. Please don't directly measure insulin levels and say that patient has insulin resistance. No. Remember, insulin levels, insulin tends to be a fluctuating hormone, right? And insulin level in itself, in isolation, has very little clinical significance. So do not measure insulin levels in isolation to diagnose anything, right? It's only useful if you have hypoglycemia and you want to see whether the patient has insulin dependent hypoglycemia or insulin independent hypoglycemia. It is not useful in this situation, right? So do not measure insulin levels and try to kind of make a diagnosis here. That please be careful of this. Right now, so you have a HOMA IR. HOMA IR is a surrogate marker of insulin resistance where you use insulin level and glucose level, right? So all you have to do is ask for an insulin level, fasting insulin and fasting glucose level. And then based on that, there is a formula which you use for calculation. It's simple to use formula, right? Simple to do test also, right? Just have to send the samples and calculate the formula. And if the value is more than 2, or in some studies I use 2.5 as a cutoff, that's marker of insulin resistance, right? So it's again a very simple test to do. That's why a lot of people do this test. But even though this test is simple and it is give me 1 second.
Yes, no.
Yeah. So yeah, sorry for the quick interruption. Okay. So the point is that HOMA IR, yeah. So the point is that the HOMA IR, though very simple to perform, right, very intuitive in making a diagnosis, but it is more of a research tool rather than trying to prove that patient has insulin resistance. Do not try to prove that the patient has insulin resistance. Insulin resistance is a clinical diagnosis. Look for acanthosis, look for skin tags, look for metabolic syndrome. Do not look for HOMA-IRs. You don't need HOMA-IR to confirm the diagnosis, right? So that is something you have to be careful. So I generally discourage people from asking for this test, right? Because it has very little use, right? Don't ask for this extra unnecessary test because even if you ask for it, even if you prove, kya kar loge? What are you going to do, right? Are you going to track this, follow this up? No, it's not a very good idea to track HOMA-IR, right? So it's a marker, it's not a target. So keep this in mind, right? Essentially, this is where I started when we started the lecture, right? Another similar test is called Quickie, which is slightly more, useful than HOMA-IR. Again, use the same two, values, that is insulin and glucose level, but of course, you calculate it in a logarithmic way. It's a simple test. It is slightly more, sensitive and specific compared to HOMA-IR. And the value here, it's a negative correlation. So value is less than 2.33 is a marker of insulin resistance, right? So that's the quickie test, right? So which is given here. Again, a very simple and easy to perform test, but just because it is simple and easy does not mean that you should be doing this test, right? Okay. The test which, if you want to do one test, probably you should do triglyceride glucose index, right? Triglyceride glucose index is a better test to do, quite simply again because you're not asking for any special test. Most of your patients as a part of a panel get glucose test done and get triglyceride done. So, and this triglyceride glucose index is actually also something, though not a very hard thing you should be following, but still something very useful for following, right? So if you again want to do it as a baseline and then follow up, it can be useful. But generally speaking, again, it's still a marker and not a target, right? But it can be used as a target if needs be so, right? So you can see the formula here. All you need is a fasting triglyceride and fasting glucose. Put it in the formula, and the value of more than 8.5 to 8.8 is generally considered insulin resistance, right? So again, it's a very simple to do test, but a very close and important marker of insulin resistance here, right? Another test which is now emerging to be very important, right? This test was initially being developed for type 1 diabetes, right? But eventually they found that it is actually more useful in type 2 diabetes or insulin resistance. This is called the estimated glucose disposal rate. Again, very simple thing to do. Don't require anything very special. You just require the patient's, basic parameters. You can see the formula. So you require the waist to hip ratio, BMI of the patient, whether the patient has hypertension or not, and the HbA1c of the patient. So basically, you don't require any special test, right? It has, though it is, less studied, it's been less studied. It is now a lot of data is emerging. In fact, there's a very recent paper which looked at this useful estimated glucose disposal rate. It uses ready to use parameter. No insulin measurement is required. But most importantly, the reason why this is a very good test is that they have found clinical studies that this test has direct correlation with cardiovascular and renal risk, right? So that's why it's a very useful test for clinical practice. So if you want to do one calculation, again, like I said, don't require any special test. You just require patients, anthropometric parameters and the HbA1c, which anyways you're going to do, right? So just require these things. And by doing this, you are able to then calculate the estimated glucose disposal rate. And this value less than 8 is suggestive of insulin resistance. Less than 6 is suggestive of more severe insulin resistance. And this has direct correlation with future risk. And also this is not just a marker, but it's also a target, right? Remember, if you reduce the BMI, reduce the waist hip ratio, reduce the HbA1c, you reduce the glucose, you in fact increase this value. And by increasing the glucose disposal rate, you are actually improving the patient's outcome, right? So that is something why this test, if you want to do one test, one thing, this is the one you should be doing, right? Rather than any of the other tests. The second sort of good one is triglyceride glucose index, but don't do quickie and HOMA-IR in clinical practice. They're very little used in clinical practice, right? I told you this. EGDR is now emerging as a very important test for cardiovascular and renal risk marker. It has direct correlation with CVD risk, diabetic nephropathy risk, mortality risk also, right? So that you can see. And the EGDR, the lower the well, the the lower the value, the more the risk, right? Higher the value, less the risk. So it's a negative correlate here. And you can see here the survival probability in relation with the values also, right? So this is the graph. Okay. Right. Now, so let's compare these tests, right? For mortality prediction, the best test is the EGDR, I told you, right? So mortality and CV risk prediction. For metabolic syndrome prediction or metabolic syndrome diagnosis, triglyceride glucose index is a good one, which is most useful for research correlation. Quickie. Quickie is a very good test. It has very strong correlation with the CLAMP study. So if you want to do as a, I'll say Matsuda index is also very good replacement. But for practical use, I think EGDR and triglyceride glucose index are the tests which you should be doing because it has good correlation with this, right? But in clinical practice, what I'll suggest is again, rely more on clinical judgment, clinical features, rather than trying to rely on these lab tests. These lab tests may be useful more for research, less for clinical practice. But in clinical practice, if there's one test you should probably, calculate is the EGDR, because that has correlation with cardiovascular and renal risk factors, and it can also be a very good target to chase. Okay. In special population, of course, type 1 diabetes, EGDR is actually specifically was developed for type 1. In adolescent and children, we don't have the cutoff value, so should probably not be using it in this condition. Pregnancy also, we don't have cutoff, so you should not be using it in this condition. And severe insulin resistance syndrome, it's better to do genetic tests rather than looking at these parameters, because again, this will not tell you much about it, right? So again, precision versus practicality. These tests do give us more insights, but whether they are useful in clinical practice, that is something you have to be very careful. High precision, low practicality are clamp studies, tracer studies. Moderate precision, moderate practicality, probably I'll say the OGTT based tests. And low precision but high practicality are the EGDR and triglyceride glucose index. So these are all more useful tests, right? So again, keep all these things in mind while doing a biochemical assessment of this test, right? Okay, we'll take a couple of questions from the audience. Yeah. Okay. Right. Somebody has asked, does this patient have SIRS, 36 female with type 2 diabetes? They're given some treatment, active married life, sugars are very high. I mean, to the anonymous attendee, I think this is a clinical case situation. Let's not discuss these right now, more in a theoretical framework. I get your point. Yes, the insulin requirement is very high for this patient. Whether this patient has insulin resistance or severe insulin resistance syndrome, I would not be able to tell you without seeing the patient, right? So I think that would be wrong for me. But yes, insulin requirement is very high, and probably if you see this patient, you do have the patient having severe insulin requirement. But of course, a lot of the time there could be other reasons also for the same. So probably okay. Let's then move on to the fourth part and the last lecture for today. Are the clamp studies. So like I said, clamp studies, again, I'll give you a basic theoretical framework. It is mainly used for research. It has very little use in clinical practice, but a lot of lot of you requested this. So we have kept this as a chapter, as a lecture here. And again, it's very important again to understand this as a concept. So if you understand this, you will be able to kind of look at this thing, right? Okay, so clamp studies are actually gold standard for measurement of insulin resistance. So if you want to do research, or if you want to prove that your drug, let's say Zuventus wants to prove that lobeglitazone is a very good drug for insulin resistance, then they have to do clamp studies to prove that, right? So clamp studies are more useful for research. Okay, we'll see what they are and what it is. Now, why clamp studies are important? Why should you do it, right? The reason is, and this is again fundamental to understanding, why should you not order a simple insulin test, fasting insulin level? I've seen this being ordered. Fasting insulin level in isolation cannot be interpreted, because remember, insulin is always paired with glucose. So if the glucose level, even in a normal person, if the glucose level is low, the insulin level will be low. If the glucose levels are high, generally, if the patient's body is able to produce insulin, the insulin level will also be high. So you have to pair it with glucose, right? You have to combine it and understand it from the context of glucose. You cannot, understand it in the context of isolation, right? Because they are correlated, right? Let's say you're doing some study where you're giving IV glucose. If you're giving IV glucose in a normal person, the insulin level will also go up, right? And if you are giving, if the glucose level is going down, the insulin level will also go down. So both have to be, both are linked. So in order to study insulin resistance in isolation, you have to clamp one of these parameters. You have to fixate one of these so that you can measure the variation in the other, right? I hope that point becomes clear. Right? It'll become more clear as we go on. So basically, you clamp one variable at a predetermined rate, and then you see the response of the other variable, right? So that is how ultimately you do it. Now, this has been seen in other neurophysiological studies, but the person who actually pioneered this is one person who is very famous, and you know him. It's Charles DeFronzo, right? So DeFronzo is a guy who actually came up with this concept, and he's a legend in the field of diabetes and endocrinology. But I think one of the things he learned was one of the things he pioneered and championed was the clamp studies, and the clamp studies actually allowed for the lot of next generation of drugs from being developed. Right now, there are two clamps. There are many clamp studies, but there are two ones which have stood the test of time. One is what is known as a euglycemic clamp, or also known as hyperinsulinemic euglycemic clamp, or also known as euglycemic hyperinsulinemic clamp. Simple term, euglycemic clamp, right? Euglycemic clamp is the gold standard for measurement of insulin resistance. But if you want to see the beta cell function, the gold standard for measurement of beta cell function is hyperglycemic clamp. So euglycemic clamp is for insulin resistance, hyperglycemic clamp is for beta cell function. Just like your HOMA IR for insulin resistance and HOMA beta for beta cell function, same way you have euglycemic clamp for insulin resistance, hyperglycemic clamp for insulin for beta cell function, right? So keep this as a fundamental concept in mind. Okay. Now, let's see what is the basic principle of euglycemic clamp. So in euglycemic clamp, what you do is you give insulin, you give glucose, right? First, you give insulin. So by giving insulin, you try to lower the glucose, right? And keep the glucose in a euglycemic range in a range of 80 to 90 milligram per deciliter. Now, what you have done is you have given insulin infusion, right? And let's say patient's glucose was 150. You lowered the glucose down to 80 to 90 and try to then maintain a steady state. Now, you will tell me that if I'm giving insulin from outside, right, and person is normal, will the glucose maintain in steady state? No, the glucose will start dropping, right? So how do you prevent hypoglycemia? You give glucose infusion. So that is when you start glucose infusion, right? So you are giving insulin infusion to lower the glucose, and then you are giving glucose infusion to keep the glucose steady, right? Now, at this point of time, what are the things which are acting in play, right? So one is the glucose going inside the cells, right? So glucose going inside the cell is dependent on the insulin. It's dependent on the insulin resistance, right? Also, your body's own insulin production, which is there, right? Now, what you have done is you have clamped one of these variables, right? By giving insulin from outside, you have clamped body's own insulin production. So you stopped the body's insulin production, but you're not stopped the insulin resistance, right? So since you stop the body's own insulin production and the glucose level is maintained, the amount of glucose required by you, right? Okay, let me put it this way. Glucose level is maintained. ये glucose जा कहाँ रहा है? Where is this glucose going? This glucose is going inside the cell. What helps the glucose go inside the cell? Presence or absence of insulin resistance or insulin sensitivity. Now, if you have more insulin resistance, right? More insulin resistance, less glucose goes inside the cell. You have less insulin resistance, more glucose goes inside the cell, right? Now, when the glucose goes inside the cell, the glucose levels comes down, and then you have to give more glucose from outside to increase the glucose level. So, if you require more glucose to maintain the steady state of the glucose, that means the body's cells are more insulin sensitive, and hence you have less insulin resistance. But if you require less glucose to maintain the steady level, that means that the cells are more insulin resistant and you require less glucose to maintain the steady state. Get my point? So higher glucose infusion rate means greater insulin sensitivity. Lower glucose infusion rate means greater insulin resistance. Right? I hope this concept is clear. Think about it, go home, listen to this lecture again. We'll put it up again in the, once the recorded version. Go home and listen to this point again. Think about it. If you still have questions, we'll discuss this next time, right? So this is the fundamental principle of clamp, right? So how do you do this? Patient comes after overnight fast. You give IV, you put an IV catheter, you give insulin infusion, then you give variable rate of glucose adjustment, and you maintain a steady state of level. And then you see, all you have to do is you have to see the glucose infusion rate, how much glucose you have to give to maintain the steady state of the glucose, right? Now, in terms of cutoffs, right, these are the values. So if it's 7.5, it is normal sensitivity. 4 to 7 is intermediate, and less than 4 is considered insulin resistant. So less amount of glucose infusion required, right? More insulin resistance and vice versa. Okay, so that is how you do the euglycemic clamp study, right? Okay, so this is where I will ask the poll question for the clamp, and we'll also take a couple of questions which are there from the audience. Okay, so which of the following statements about hyperinsulinemic euglycemic clamp or the euglycemic clamp is false? It is considered gold standard. The glucose infusion rate directly reflects insulin sensitivity, right? So higher glucose infusion rate, higher insulin sensitivity, is that correct? It can be easily implemented in routine clinical practice. It can be combined with tracers, and higher glucose infusion rate indicates greater insulin sensitivity. Higher, okay, I think, okay. Right. So I think there are more than one question, which is more answer is a little flawed question, right? So basically, I think let's get back to this point here, right? This is a point. So just once again, I'm saying what you're doing is, remember you have a cell, right? The glucose entering the cell is dependent on insulin resistance. So if you have more insulin resistance, right, less amount of glucose will enter the cell. Understand? So in the clamp study, what you've done is you have clamped body's own insulin production and you're giving all the insulin from outside. You are lowering the glucose and then giving glucose to maintain that glucose level, right? Now, once you are in that steady state situation, right? Once you're in the steady state, the glucose is coming down because the glucose is entering the cell. The amount of glucose that is entering the cell is directly equal to the amount of glucose that you're giving from outside. Understand? जो भी आप ग्लूकोज बाहर से दे रहे हैं, it is going inside the cell, right? That now, if you're giving less amount of glucose from outside, that means less amount of glucose are going inside the cell, and that means you have less insulin, you have less insulin sensitivity and more insulin resistance. But if you are giving more glucose, then you have more insulin sensitivity and less insulin resistance. Just keep that in mind. I repeated this just for your understanding, right? Think about this question. And this question is, like I said, a little, so we'll not, probably it says which of these is not correct. Yeah, so it's a correct question, right? It's which of these is false. So it's a correct question, but yeah. So, but there are two options which are same. So I think that's it. Probably invalidates that question a little bit. Okay. Let's take a couple of questions from the audience which are there. Okay. Yeah, Dharmadev will allow you to unmute in a few minutes. Neera Goswami, just help how to manage. Is there anything I'm doing in a wrong way? Manage what? Okay, we'll come to that. Okay. Yeah. Okay. So question. Okay. And then we had the second clamp study, which is the hyperglycemic clamp, right? Which is the other aspect of the clamp. So remember, the euglycemic clamp was for insulin resistance. The hyperglycemic clamp is mainly for looking at the beta cell function. Okay. So if you want to measure the beta cell function, the gold standard is the hyperglycemic clamp. Now we'll not be discussing hyperglycemic clamp in detail, right? Again, just for your understanding, you have first phase and second phase insulin response, and this is how you'll be measuring in the hyperglycemic clamp. Again, not an area of discussion, right? Remember, these studies are mainly done. These are human subjects, human subjects as lab rats. It's not something you do in clinical practice. It's mainly done for research purpose. You're not doing this in real life studies, right? And again, these are more of used from a research perspective. Okay, so it's mainly for research, mainly for pharmaceutical drug development, physiological studies, and you can of course do other forms of research also. It's a it's a resource intensive test, and it's mainly done more of a it's a high precision but low practicality in terms of trade-off, right? So I'll end today's series of lectures here, and we'll now take your questions, and we'll also allow a few of you to unmute and ask some questions. Okay. Right. So if you wish to unmute, please just raise your hand, and we'll allow you to unmute. And put your question. I think somebody had a question regarding a case. If you want to unmute and ask. All right. Okay. So I think we are actually way past time. We are, supposed to be 1 hour lecture. We already 1.5 hours. Hope you enjoyed it. And we'll now in the next week going to discuss about the treatment aspects. So if you have again treatment related questions, please join us next week where we'll be discussing about the treatment, where we'll be discussing about lobeglitazone, pioglitazone, and other drugs which are useful in clinical practice for this condition, right? So yes, so I think we can end this. Amit?
Yes, sir.
Yes, please.
So as you already unveiled the next week proposal and the idea, obviously. So it has been indeed obviously one more than 1 hour, and attendees were there. So it has been indeed interesting, informative, and well in interactive session, I believe. So I would be failing in duties if I don't thank you. Obviously, express my heartfelt thanks. The kind of energy you always bring in such webinars, and obviously our esteemed participants who joined all across, not only from India, obviously, as I mentioned in the beginning, because I was seeing the last week list, many are doctors from outside. So that's the good part of this webinar. So I thank you all once again with a promise, as Dr. Lakhani has mentioned, to meet next week for the third lecture. So yes, sir, we can.
Thank you.
Yeah.
Yes. Thank you so much, Amit. And thank you to Zuventus for this. And yeah, so we'll meet you next week for the treatment aspect. So I think it'll be very interesting. So again, your treatment related questions, please bring it on next time. And we'll be discussing that next week. And thank you again. And good night to everyone. And see you. Bye.
Thanks, sir. Thanks a lot. Thanks, everyone. Yeah.
Bye.
Take care. Bye.